A knee replacement can be life-changing in many ways. Number one, it's understanding what's the baseline function of our patients and what are their goals. Sometimes I have conversations regarding patients wanting to play with their grandkids or even go fishing. And these are things that patients enjoy. They're by no means why we should limit ourselves to what we can do in life just because we have pain. And that's where a knee replacement can really help, because it gives patients the opportunity to do these things with hopefully minimal to no pain. A perfect candidate for a knee replacement in particular is somebody who has osteoarthritis. And a lot of times this can be just primary osteoarthritis, which is essentially the degradation of cartilage with exposed bone where you're rubbing bone on bone. Other times it can be after people have had a previous injury, ACL reconstructions, meniscal injuries, where the cartilage can start to become damaged from those injuries itself. And this essentially leads patients down a path where they're having increasing pain within their knees. They have difficulty walking. They hear a lot of clicking, popping, and catching. I was trained initially to do manually instrumented knees. So it was good because it developed a nice foundation. As I was coming through my training, mainly within residency, the Mako robot started to become more popular. And I was actually introduced to it by one of my attendings. And I knew immediately once I walked into the OR and saw my first case, I knew that's what I wanted to do. Regarding robotic assisted knee, we have the capabilities of understanding their deformity and therefore planning our implants down to 0.5 millimeter and 0.5 degree difference to therefore give them, number one, a knee that feels more native to them, number two, help preserve bone, and then number three, ultimately give them a better postoperative outcome with improved range of motion, decreased pain, and therefore hopeful decreased narcotic use on top of it. The path to knee replacement, we typically get x-rays when they initially present to our clinic, so then we can actually diagnose them appropriately. I think that's something that's overlooked at times, but it's ultimately looking at weight-bearing x-rays so we can really see what's the deformity, what's the injury, and how can we treat it appropriately. I've had patients come back and say, I'm not able to put on my socks and shoes, I can't get in and out of a car, why is that? And it's essentially because in arthritis, the bone ends are exposed, and that's actually where we have our nerve endings. And so as we begin to rub bone on bone, it irritates and becomes painful to an extent that we can't treat without surgical intervention. And unfortunately, especially with arthritis itself, it is progressive in nature, so it will get worse over time. My goal is to help patients before they get to the point where it's become so debilitating that they can't do the things that they want to do in life. I've told multiple patients that if there was a place where I would want my parents to have their orthopedic procedures, it would be here. And the reason for that is we have the capabilities of keeping them inpatient, and there's not another facility in this area that only does orthopedic cases, maybe outside of a surgery center. They get the care of an orthopedic trained nurse, anesthesiologist, the scrub techs in the OR with the appropriate physical therapist who ultimately give them the care that they need.